Well, good afternoon, everybody. Thanks for joining us today. Today, we're going to be having the first of a set of lectures on pulmonary hypertension. The lecture we were going to have last week that got canceled was also about pulmonary hypertension. That one's been rescheduled for the 14th of April. But today we have Brandon Jakubowski, who's joining us from UT Southwestern, who's going to give us a great introduction and overview for pulmonary hypertension. So, Dr. Jakubowski, thanks again for joining us, and please go ahead and take it away.
Awesome. Thanks for the introduction, Michael, and thanks for having me. Just to make sure you can see my slides on the screen, correct?
Yep, it looks really good.
All righty. So, like Michael said, my name is Brandon Jakubowski. I'm one of the faculty here at UT Southwestern in Dallas, Texas, and my primary clinical focus is on pulmonary hypertension, which I'll be discussing with y'all in some detail today. And this is just a brief overview and kind of learning objectives for the talk. Today, I'll really be discussing some of the historical perspective from the World Health Organization classification, along with the etiologies of pulmonary hypertension. After that, we'll move on to discuss some of the epidemiology, the natural history, and I think probably the most important part of this talk is really the risk assessment and prognostic factors that we consider when discussing patients with pulmonary hypertension. And then, as Michael said, at a later time, one of my colleagues, Dr. Hardin, will talk about some of the invasive hemodynamic assessment along with the treatment algorithm for at least PAH patients. So the history of PH itself is actually a really fascinating one, and one that is not particularly old either. Really, the first case of pulmonary hypertension was probably recognized in 1891 by this gentleman, Ernst von Romberg, in which he described an autopsy of a patient that he described having pulmonary vascular sclerosis. And about 10 years or so later, Abel Ayerza was in Spain and described a kind of a case series of 10 patients or so that had chronic cyanosis, polycythemia, as well as dyspnea, and had a kind of eponym named after him, Ayerza syndrome, which is probably a cohort of patients that ultimately ended up having congenital heart disease and Eisenmenger's physiology. It wasn't until a few decades later that Werner Forssmann in Germany actually conducted the first right heart catheterization in a human. It's a really fascinating story, but he actually performed it on himself. I highly recommend people go look into that story. I don't have time to give it in detail, but it's a really fun one to read. And a few decades after that, Dresdale is actually the first person who coins the term primary pulmonary hypertension, which he says is defined as a condition in which an elevated pulmonary artery pressure exists without a demonstrable cause. In that same decade, in the late 1950s, Paul Wood describes the dynamics of blood flow through the lungs and the factors that contribute to the resistance encountered by blood as it passes through the pulmonary circulation. And it's really in the 60s where the story starts to get particularly interesting. A physician named H.P. Gertner is working at the University Hospital in Bern, Switzerland, and notes that there's a significant increase in the number of patients he's diagnosing with primary pulmonary hypertension. He finds these patients are often older, they tend to develop more rapid disease, and then they were more commonly obese. And in questioning these patients, he actually finds that 55 of 70 of them are taking a medication that was widely available over the counter at the time called Immunorex. And this medication is actually an appetite suppressant that's used to treat obesity at the time. And if you know anything about the molecular composition of methamphetamine, it has a very, very similar molecular composition to it. In kind of the early 70s, similar reports are being described in Austria and Germany, and it's because of this kind of retrospective data, we actually find that about 1 in 500 patients who are using Immunorex end up developing pulmonary hypertension. So it ultimately gets removed from the European market in 1972 because of this. At the same time as we're learning more about pulmonary vascular disease, the WHO, or the World Health Organization, really does an excellent job of bringing together physicians in order to come up with consensus statements and guideline statements in order to understand best how to treat and how to conduct research on patients with pulmonary hypertension moving forward. It was really that kind of Immunorex pandemic in the 1960s that prompted the WHO to start these world symposia. And since that time, you can see since about 1973 or so, or 1998, we've been meeting every 5 years or so to have world's experts kind of meet and discuss pulmonary hypertension. The last one being just a year or so ago in Barcelona. And I use this slide primarily to highlight some of the, at least what I find fascinating about pulmonary hypertension. It's an incredibly small field, very, very small. I think this last WHO meeting we had, there was about 2,000 people in total, which is in stark comparison to the first meetings, which there was, 13 people attending. But despite the small size of pulmonary hypertension within the medical field, we have 3 Nobel Prizes that have been awarded because of pH research, essentially. The first one being to Forsman and some of his French colleagues for the discovery of the heart catheterization. The second one being for the discovery of prostaglandins and their effects as a biologically active substance. And the last one for the discovery of nitric oxide as a signaling molecule within the cardiovascular system. And over the course of these last several meetings, you can see the definition of pulmonary hypertension has changed dramatically. And in that first meeting, all we had really was pulmonary hypertension being defined as a mean pulmonary artery pressure greater than 25 millimeters of mercury, without any other kind of insight as to other subcategories of pulmonary hypertension, except for, interestingly enough, exercise-induced pulmonary hypertension. And this definition has changed, obviously, over the course of time as we've gained new insight and new information into how the disease process acts. And in 2022, we updated this definition to include a mean pulmonary artery pressure greater than 20, a wedge pressure less than 15, and a PVR greater than 2 Woods units. And that definition was not changed in the latest WHO meeting in Barcelona here last year. And this revision was based on accumulating evidence that said that the normal resting pulmonary artery pressure is approximately 14 plus or minus 3 millimeters of mercury, with an upper limit of normal around 20. And I've included this graph on the left, which is taken from a large registry detailing a broad incident and prevalent patient population with pulmonary hypertension. And you can see the classic pH definition is shaded in this gray region, and really demonstrates these individuals that have a marked mortality risk. But the pink region is indicating patients that have a mean pulmonary artery pressure of 19 to 24. And despite that small kind of hemodynamic category, this actually represents 23% of that cohort. And these patients actually have a mortality hazard ratio of 1.18, which is statistically significant compared to the reference group, and accounts for a 22% higher adjusted mortality. Thus, waiting until 25 millimeters of mercury misses a fairly large cohort of patients at elevated risk. And additional studies have shown that a PVR greater than 2 Woods units is also associated with increased mortality. As shown on the graph on the right-hand side, there's a clear upward trend towards starting at Wood units of approximately 2. Hopefully, including these patients in the new hemodynamic definition helps us with earlier identification and intervention of pulmonary vascular disease, though we don't have firm data to support this quite yet. In the latest WHO meeting, we've recharacterized and we've reclassified the schema over the course of time. And this is really what we've landed on in the most recent guideline statements, in which we've classified patients into 5 categories of disease based on several factors. 1, of how they clinically act, 2, how they respond to treatment, and 3, really in order to best inform us for how to properly perform research studies with well-defined patient populations. Group 1, as I think you probably know, are patients that have pulmonary arterial hypertension or precapillary pulmonary hypertension. Patients with group 2 disease are commonly thought to be associated with left heart disease. Group 3 disease are patients that have lung disease of varying kinds. And group 4 are patients that really have pulmonary artery obstructions, the primary one of which is chronic thromboembolic pulmonary hypertension. And group 5, we've kind of lumped into our general wastebasket term. These are patients that may have multifactorial mechanisms or unclear mechanisms that we don't really quite understand. And within each of these groups, you can see group 2 is a very common disease and group 3 is less common, but compared to group 1, 4, and 5, these subcategories of pulmonary hypertension are far rare, despite us having probably the largest evidence base for how to treat them in particular. I'll go through each one of these in more detail because I think highlighting the specific subcategories and diseases within those subcategories is very instructive and informative for how I, at least, am approaching a patient in my own clinic. So group 1 disease really entails patients that have precapillary pulmonary arterial hypertension. And we'll see on the next slide, the majority of these patients are either idiopathic or associated conditions. And the associated conditions are primarily connective tissue diseases. These are things like scleroderma, lupus, dermatomyositis, polymyositis. We see patients that have HIV infection that have pulmonary hypertension or portal hypertension leading to portal pulmonary hypertension, as well as congenital heart disease. PVOD is a kind of subset of pulmonary hypertension in which your heart catheterization will have hemodynamics that look like precapillary disease, but on pathology and histology, there's a very prominent venous and capillary involvement, and these patients don't actually respond as well to pulmonary hypertension or pulmonary vasodilators nearly as neatly. And then the last column I'd really like to highlight here are patients that have associated pulmonary hypertension with drugs and toxins, which we'll discuss here on this next slide. I've created this to kind of subdivide definite and possible associations of pulmonary arterial hypertension with these drugs. On the left-hand column, you can see these are the medications we have firm evidence that they are associated with the development of PAH. And these medications primarily include, a lot of these weight loss supplements. You see Aminorex on here, Benflorex, dexfenphoramine, and fenfluramine previously was available in fen-phen as a large contributor to pulmonary hypertension in the early 90s. Thankfully, a lot of these medications have now and since been withdrawn from the market. Other medications to highlight in this column are really dasatinib. This is a common one that comes up on board exam questions and one that we see frequently in clinic as well. And then mitomycin C is one of those interesting ones that's actually associated with that PVOD phenotype. And the last one that I think is probably mentions a highlight here is really methamphetamines are a very large cause of PAH within pulmonary hypertension clinics when asked patients directly. The medications in the possible association column are those that we don't yet have enough data to support they have a definite association. Still, if I see a patient in my own clinic that I am worried about precapillary disease, I will often see if we might be able to substitute medication that may be used for a clinical purpose with something else that doesn't have a possible association. Over time, we may develop enough information and enough data to move these possible meds or possible associated therapies into the definite column. Moving on to group 2 disease, this really is PH associated with left heart disease. And the latest meeting at the WHO, we really emphasized trying to disaggregate various forms of left heart disease instead of just saying all patients that have left heart disease should be identified and treated equally as such. This really is patients that have heart failure. That can include patients with diastolic heart failure, as we see very commonly, as well as systolic heart failure. And then they've tried to put more focus onto determining specific etiologies of disease with pulmonary hypertension. That way we can understand if myosin inhibitors, for example, and HOCM have any bearing on the development of PH long-term. Similarly, this is true for valvular disease. We've kind of disaggregated aortic valve disease and mitral valve disease, knowing that these are two very common causes of pulmonary hypertension, along with mixed valvular disease. Group 3 disease is primarily disease associated with lung disease or hypoxia. That includes patients that have COPD or emphysema, those with diffuse interstitial lung disease, as well as an entity called combined pulmonary fibrosis and emphysema, otherwise known as CPFE. And this is a really important one to identify because patients in this subcategory of pulmonary hypertension tend to have a much more severe prognosis and rapid progression of disease. Other parenchymal lung diseases are included in this definition too. This is a bit tricky because there are parenchymal lung diseases that we'll discuss in the group 5 category, but it's essentially those that are not in group 5 that are still lumped here into group 3. Additionally, we include the non-parenchymal restrictive lung diseases. You'll see this with severe hypoventilation syndromes, people with severe kyphoscoliosis, or patients that have had pneumonectomies. And interestingly, hypoxia without lung disease or without lung disease, something known as Monge's disease, can be seen at high altitude, along with developmental lung disease. Group 4 disease, I think most people know the importance of recognizing chronic thromboembolic pulmonary hypertension, but group 4 is really pH associated with pulmonary artery obstructions, and this can be of obstructions of any kind. So pulmonary artery sarcomas are an infrequently seen mimic of CTEPH, but other malignant tumors can involve the pulmonary vasculature. This includes RCCs, uterine carcinomas, uterine leiomyomas, interestingly enough. And then we see patients that have a pulmonary arteritis without a clear identifiable connective tissue disease. Sometimes patients present very similarly to what a Takayasu's patient would present like, but purely involving the pulmonary vasculature for some reason. And then our last grouping is really this group 5, which is the multifactorial or unclear mechanisms. And this includes patients that have hematologic disorders. So we see that the chronic hemolytic anemia is primarily sickle cell anemia, along with chronic myeloproliferative neoplasms. These include polycythemia vera, includes essential thrombocythemia. We've lumped sarcoidosis, pulmonary Langerhans cell histiocytosis, and neurofibromatosis into this category, along with some of these metabolic disorders, glycogen storage disorders, and Gaucher's disease. Pulmonary tumor thrombotic microangiopathy is a very interesting disease state in which you're essentially getting small tumorlets that are embolizing into the pulmonary vasculature, causing acute onset right-sided heart failure. And then we put fibrosing mediastinitis because of its complex multifactorial mechanisms in this grouping as well. I'd like to spend a little bit of time talking about the epidemiology of pH. It's actually a very large global health issue. We think it affects about 1% of the population in total. And, you know, as our population tends to get older, we're going to see more and more pulmonary hypertension because of the presence of cardiac and pulmonary comorbidities that develop as people age. This graph I've included here on the right-hand side of the screen indicates the incident rate of PH in a group of patients from Ontario, Canada, I believe, between 2003 to 2012. And you can see pulmonary hypertension increases over that time period. The incident rate of pulmonary hypertension increases over that time period. And this is predominantly made up of both group 1 or group 2 and group 3 patients, with the group 2 patients making up the largest percentage of that PH cohort. And this is unsurprising. You know, globally, left heart disease is the leading cause of pulmonary hypertension, subsequently followed by chronic lung disease, not dissimilar to this group in Ontario. In certain developing countries, you know, these probably are understudied, but congenital heart disease and certain infectious diseases like HIV and schistosomiasis may represent a larger cohort of pulmonary hypertension, but we just don't have the data really to prove that at this point in time. When we look at the specific breakdown of pulmonary hypertension, as we mentioned, left heart disease and lung disease are really the two most common causes of it. In the groups of patients that I see in clinic, you know, CTEPH, this miscellaneous group in pulmonary hypertension, this makes up a really small wedge of this pie here. And within group 1 disease, it's about 51% of patients that have associated conditions, and the other half is a smattering of a very small percentage of hereditary diseases from known genetic mutations or idiopathic patients ultimately. If you take this pie on the right-hand side of the slide and just look at the associated causes, we know that about 50% of the associated causes of pulmonary hypertension are from a connective tissue disease. And like I mentioned, these are things like scleroderma, lupus, dermatomyositis. The other half of that pie is really taken up with a smattering of congenital heart disease, HIV, drugs and toxins, along with portal pulmonary hypertension. The natural history of pH is important to understand as, you know, we have pretty solid data and a solid evidence base that untreated PAH patients generally have a poor prognosis. And this comes from the days before therapy was available. And we know that their median survival historically has been approximately 3 years or so. But with modern PAH therapies, especially with combination therapy, people are living up to 10, 15, 20 years in some cases. Group 2 and group 3 often mimic how the underlying disease is progressing. So people that have worsening heart failure, people with worsening fibrotic lung disease, their pH tends to progress in a linear fashion compared to their underlying disease. And as I mentioned, CTEPH is a potentially curable disease. It's a really nice disease to treat with pulmonary endarterectomy. So recognizing it is incredibly important because untreated cases do develop severe progressive RV failure. And the graph on the bottom part of the screen really illustrates how key invasive hemodynamic parameters evolve across the spectrum of PAH, from clinical improvement to disease progression. And as the disease worsens, PR is steadily climbing, reflecting that increase of obstruction and remodeling of the pulmonary vasculature. In advanced stages of the disease, you can see that the mean pulmonary artery pressure actually plateaus. And this is really because of a reduction in your cardiac output and your cardiac index, which limits your pressure generation despite worsening of disease. As RV failure tends to ensue, the right atrial pressure increases along with reductions in your stroke volume index and your mixed venous oxygen, all declining. And recognizing where a patient is lying on this curve can really help inform prognosis and whether or not you need to be therapeutically escalating their management. It also underscores kind of the importance of achieving early reversal. If you have a patient that's, a third of the way through this graph and you can get them onto therapy, you may be able to get them significant improvement from a reduction in their disease burden and progression over time. I'll move on to the discussion about risk and prognosis. And for us, risk stratification is incredibly important. It's useful to predict outcomes along with guiding treatment decisions for patients with PAH. And our ultimate goal in treating patients is to have them reach kind of this low risk mortality status. This is usually done by a validated risk assessment tool. And of all of the risk assessment tools, which I'll dive in here into a little bit, you'll find that there are kind of three main predictive prognostic factors within these tools. Those include the WHO functional class, patient's 6-minute walk distance, as well as cardiac biomarkers. And it's important to understand that not all of these prognostic tools are specific to PAH alone. Variables themselves may not be adequate in isolation for guiding individualized treatment decisions. But for me, despite not having a ton of data in risk stratification tools, the echocardiographic assessment serially is incredibly important. If somebody is having an increasing RV dimension, their TAPC is getting lower, their TAPC to SPAP ratio, kind of a marker of coupling, is worsening, or they're developing an effusion. These are all indicators that someone's disease is worsening, and you may want to be more aggressive about treatment. Let's talk about the data behind each of these variables used individually. You'll see that they're actually useful in a sense. This is a Kaplan-Meier curve analyzing survival based on a change in functional class at follow-up in patients who are initially WHO functional class 3 at diagnosis. And you can see on this graph that patients are grouped whether they improved to functional class 1 or 2, whether or not they remained in functional class 3 or worsened to a functional class 4. And patients who have improved functional class really have the best prognosis with a 3-year survival of 84%. Patients who have progression to functional class 4 states tend to have the worst outcomes. You can see only 29% of these patients are surviving at the 3-year sensor date. And this study really reinforces the importance of serial risk stratification with a functional class and validates who functional improvements in a patient's functional class confer a significant survival advantage, where unfortunately vice versa is also true. This Kaplan-Meier curve really shows the estimated proportion of PH patients remaining free from a clinical event, which in this study is defined as hospitalization or death, stratified by their baseline 6-minute walk tests, divided into quartiles at treatment initiation. The patients in the blue line are those that have a 6-minute walk test under 300 meters and have the worst event-free survival at 3 years, with fewer than 60% of them remaining event-free at sensor date. This is in contrast to the patients in the green quartile that have a 6-minute walk distance greater than 430 and are considered a low-risk functional state. Prior to this study, it's really the REVEAL registry, which is a large US-based database of PH patients, established clinically meaningful thresholds of 165 and 440 meters as the guardrails for low and kind of high-risk status. And we still use these cutoffs for a lot of our objective risk calculators in current days. Um, Deterioration in 6-minute walk distance is associated with an increase of morbidity and mortality, though strangely, its improvement is not necessarily associated with better outcomes. We often use this as a primary endpoint in several clinical trials, but it's really only been associated with improvement in changes or improvement in quality of life for patients. It's really not a predictor of major clinical events in the short term, and it really shouldn't be used as a valid surrogate endpoint for an outcome, despite its widespread use in today's literature. This has come up in questions before. People have debated whether or not percent predicted values may be more helpful than absolute values. This has not panned out to be true. And I think it's most important to understand that the 6-minute walk distance in particular is influenced by a lot of factors outside of pulmonary hypertension itself. Patients that are older, have musculoskeletal complaints, or are deconditioned, are going to have lower 6-minute walk tests that are not due to worsening of their pulmonary hypertension or from RV failure alone. Similarly, in patients with PAH, natriuretic peptides, reflect right heart overload and dysfunction and are correlated with hemodynamics as well as 6-minute walk distance and survival, both at baseline and at follow-up. This is another Kaplan-Meier curve showing the survival probability over time stratified by baseline BNP levels in a very large PAH cohort. And just like your 6-minute walk test and your functional class, cardiac biomarkers are dynamic and can improve with treatment, and trending these over time really does add to a patient's risk stratification. On this slide, I've included several of the larger pH risk calculators that exist, and these were really formed because no single variable provides sufficient prognostic information, and these multi-parametric equations were thus derived, combining hemodynamics, exercise capacity, and clinical parameters within PAH populations. And all of these tools are externally validated for all-cause mortality and time to clinical worsening events, but they're not created equal. You can see each one of these includes different types and quantities of clinical, functional, imaging, and laboratory data, and the choice of which risk model you're using should really be based on the available data that you have, the clinical setting you're practicing, and the need for precision versus ease of use. You can see, for example, the Reveal 2.0 Lite only has 6 variables or subvariables to look at, where the ERS model, you have to plug in 18 different things. And intuitively, it makes sense that more variables may improve risk discrimination, but and truth be told, the science hasn't borne that out, and they also increase the burden to you and to your staff. So simpler tools may be better suited for routine clinical visits. But regardless of which tool you use, it's really the serial use and trending them over the course of time is what helps kind of recharacterize patients to determine if you're needing to make management decisions based on that information. I'll spend just a short time on this slide here. This is really, talking about other markers. Echocardiography, as I mentioned, is incredibly helpful. We know that right heart failure is a main determinant of patient outcomes. So for me, I'm often looking at this TAPC to SPAP ratio to understand how the RV is functionally coupled to the pulmonary artery or the pulmonary circulation. TAPC is useful, and to some extent, it's obviously very load dependent, angle dependent, but all of these other markers of RV function are also helpful to look at. Invasive hemodynamics we're often performing, every 6 months to every 1 year, depending on patient progression. We know that the right atrial pressure is an incredibly helpful tool for risk stratification, as well as some of these other baseline predictors. But interestingly, current registries really have shown that serial hemodynamics aren't much help to additional prognostication compared to the non-invasive parameters I mentioned previously. This may change over the next couple of years as we kind of have more data showing that in intermediate risk patients, this may actually be beneficial, but that time will tell. This table on the left-hand side really represents that 3-strata risk model endorsed by the 2022 ERS guidelines and stratifies patients into low, intermediate, and high risk based on their 1-year mortality. The goal is to assess patients across multiple domains to determine their risk profile. And the more parameters that you have falling into the low risk category, the better your prognosis. And for me, at least, a lot of these variables are quite intuitive. If you have a patient that's having rapid progression of disease and having repeated syncopal events, this is a patient that you're going to act very quickly on to get onto more aggressive therapy. The table on the right is actually that CERS 4 strata risk, and is to be used primarily for patients that are seen in follow-up, in contrast to the patients or to the table on the left, which is primarily for newly diagnosed patients. And notice that those three variables I talked about previously are the ones included in this risk calculator, the WHO functional class, 6-minute walk distance, and cardiac biomarkers. And ultimately, I think a question comes up a lot is, do I need to use a risk calculator? And this is a study that looked at 118 patients who were being seen at a pulmonary hypertension center of excellence. And of those patients, all of them were thought to have a clinical gestalt of having low risk status. But when they were actually their variables plugged into one of these risk calculators, 80% of them were reassigned from low risk to either intermediate or high risk, with 10% of them actually being assigned to a high risk state, a really concerning thing for a pulmonary hypertension patient. And the last thing I'll leave you here with is kind of the treatment or the diagnostic algorithm actually for pulmonary hypertension. And a lot of times you can get most of the middle column here prior to referral to a PH center. The patients that warrant referral to a PH center are really those that have a high probability of having precapillary disease, having CTEPH, or those with high urgency. So people that have severe RV failure or having syncopal episodes, have a reduced cardiac index when you perform your right heart catheterizations. But don't hesitate to send any patient to a pulmonary hypertension center of excellence. Patients that have PH-ILD or chronic lung disease associated with pulmonary hypertension represent patients that need to be seen by transplant teams soon or two, or even patients that have severe combined pre and post capillary disease. Those are patients that we're interested on performing, research studies on to accrue better data for how best to treat these patients. And with that, I will end here. I'll happily take any questions.
Thanks, Brandon. That was really, really good. I do have a question from the chat, so I'll read it to you. Let's see here. So it says, we use echocardiography as a screening tool. I know that mean pulmonary artery pressure is more accurate, but why not use pulmonary artery systolic pressure as the diagnostic criterion for pulmonary hypertension instead of just for screening and then confirming with right heart cath? I understand that the right ventricle eventually fail, causing systolic pressure to drop, but shouldn't also the mean pressure decrease? Wouldn't using mean pulmonary artery pressure directly make diagnosis and treatment monitoring faster and easier? And do you use a cutoff for pulmonary for the pulmonary artery systolic pressure above a certain threshold for screening?
That's a good question. And part of the reason for this, the latest 2022 guidelines kind of shifted from using an RVSP cutoff for your pretest probability of pulmonary hypertension towards using a tricuspid regurgitant jet velocity, in large part because of all of the variables that go into accounting for an RVSP. And the same would be true for like an echocardiographic estimation of your mean pulmonary artery pressure. If you actually look at the equations that are used to echocardiographically estimate that, they are not particularly robust nor accurate. So for that reason, that's kind of why we're still moving towards the TR jet velocity more than anything. But I think that answers your question. Let me know if not.
And I think you kind of hinted on this a little bit when you were talking about risk factor um, and prognostication. But are you comfortable when you don't have all of those risk factors for a specific calculator, and then providing prognostic information to patients if you have few variables but not all of them? Is that something that, because obviously sometimes it's hard to get everything that's required in those risk calculators, or you might not
Yeah,
have them. Do you feel pretty comfortable still providing that prognostic information to folks based upon what you do have?
yeah, absolutely. That's an excellent question. It's this has been studied, in particular with the Reveal 2.0 calculator. Some of that information, when I'm first seeing a patient, for example, like is their DLCO less than 40%, I don't have at my initial consult visit with patients. But they've actually been able to show that you can pull a lot of these individual variables out, and the robustness of the risk calculator is still there, which is part of the reason why they felt comfortable releasing the Reveal 2.0 Lite calculator, which really only has 6 variables, which most of are very easily available to you, like in the clinical setting. I still think you can make a very good kind of prognostication and risk assessment, even without some of those variables at the first incident visit.
All right, well, again, Brandon, thank you so much for joining us. We're at the top of the hour, so I'm gonna let everybody get back to work this afternoon. And thank you again for your great talk, and really appreciate you spending the time with us.
Of course, everyone take care.
All right, bye-bye.